Portsmouth has a naval dockyard and is a tri-service military city, with QA Hospital hosting over 200 serving tri-service medical personnel, called the Joint Hospital Group South, of which we are one of 5 and the largest in the country, and we have provided a veteran service since January 2020. Portsmouth's QA Hospital was originally a military hospital, built in 1908, and was handed to the Ministry of Pensions to care for disabled ex-service personnel. The Second World War saw the first civilian patients admitted. Then, following the creation of the NHS in 1948, 540 beds were transferred to the NHS, with an additional 100 beds reserved for ex-service personnel. I'm still trying to find those 100 beds. After signing the Armed Forces Covenant, the Trust agreed with me that we were frankly not doing enough for our military community, and they fully supported creating a veteran service. Veteran-aware training plays a crucial part in the service, and my first achievement was making veteran-aware training a mandatory part of the Trust induction programme. Without educating all staff to the importance of simply asking the question, "Have you served in the military?" and identifying them on our digital system, obviously with their consent, we can't support their safe discharge and offer community support which may prevent a failed discharge or readmission, which will affect the mental and general health and well-being of the patient and their family, as well as incur additional cost implications to the NHS. After performing a veterans' need analysis, one of the things I concluded was that those in the military community who need the support don't know what support looks like and how to access it, and those in healthcare didn't know what support exists, so therefore didn't know what to offer, identifying a huge gap. That's where the training and education of our multidisciplinary team is crucial to shrink that gap and empower all staff to signpost and refer. Next slide. Since January 2020, 4,324 staff via Trust induction and over 1,100 currently employed staff have received training. That's totaling nearly 5,500. The main challenges we had was encouraging our staff to ask if the patient has served in the military, encouraging them not to phrase their question asking if they were a veteran, then reminding them to identify them manually on our digital system called BedView. This manual element of the digital pathway is getting automated. To be honest, making staff veterans aware is only the beginning. There is a huge difference between making a hospital staff veteran aware and educating staff in the diverse military culture and actually giving them the tools on how to manage their military community patients' care differently, especially if there is any underlying health involvement due to military service. Our service comprises of myself and my Defence Medical Welfare Service colleague Anna, and we both show constant visibility on the wards. I believe having that visibility is also crucial, not only in clinical areas where we can educate on the spot, but also in public areas engaging with our community. I host a mini roadshow at our main entrance once a month with third-party organisations, and with my employment recognition scheme hat on, also try service recruitment so they can recruit reservists from our workforce and adult cadet instructors. When I enter the majority of wards and engage with a patient, nurses walking past often say to the patient, "See, I told you Keith would be up to see you." That's when you know you're winning and your educating is working. Next slide. How else can you evidence that your training and educating is being effective? Well, down to data collection. Since I designed and launched our veteran service, which is now being replicated across the UK, the number of former military patients who have been identified and engaged with from 2020 to present day has increased by 88%, totaling over 4,200 veterans and or their families, demonstrating that the training we're doing is working. It's not that there are more veterans, as they've always been there. We are just getting better at identifying and recording them due to training, education and data collection. Our data demonstrates information like how many veterans are seen within 1 day, seen within 2 days, and the length of time from the admission date to when they are identified on the system as a veteran. This allows me to focus our energies on the patients' areas who don't identify them in a timely fashion, making our training more efficient and focused if needed. Bespoke for that area, and I should say that we can only support those we know about, which is why I'm confident my figures will be on the low side. Next slide. What impact does training and education have on our patients and organisations? Well, I went on an acute surgical ward to provide veteran-aware training, and during the training they made me aware of a patient on the ward who is a veteran with PTSD, who needed a wheelchair for a safe discharge. But because he was no fixed abode, so homeless, our health authorities would not fund a wheelchair. I advised them where to go and what to do and offered additional support if needed, and within a few days he had a wheelchair and was safely discharged. Due to the multidisciplinary team's lack of knowledge and training in veteran support, which is no fault of theirs, he occupied and blocked an acute surgical bed purely waiting for a wheelchair for over 2.5 months. That's approximately £45,000 of NHS money misused. If the staff, including the multidisciplinary team, were veteran aware and had organised a wheelchair as soon as they knew it would be required for a safe discharge, this would have prevented this patient from being stuck in hospital unnecessarily, which done nothing for his mental health, and would have freed a critically needed bed for the trust. To put the £45,000 into perspective, if you're thinking, how can my trust afford someone in a similar role to mine? That money equates to a top Band 7's annual salary, and that's with supporting just one patient on just one ward. Next slide. Once staff have attended their veteran-aware training, they are given a veteran-aware badge. Let me put into perspective what wearing the veteran-aware pin badge means to me. I was working on an orthopaedic ward prior to this role, not knowing a thing about the Armed Forces Covenant, when a young serving member of the British Army was admitted with a fractured leg. His young wife then arrived with a very young baby, and they were all getting increasingly distressed. On approaching the wife, offering support, she said that they are newly married, the husband was on exercise in Portsmouth and broke his leg. She has just arrived on the train with baby and all the baggage that comes with. None of the family had been to Portsmouth before, so she had to navigate her way to the hospital, not knowing where she was going. They had no friends or relatives in the area. She was worrying about where to sleep for the night, where to get transport, food, childcare, etc. And they were getting more and more distressed. The only support I could think of was to signpost them to SAFA, as I had used SAFA myself when I was serving. I advised her to call SAFA and asked for her and asked for help. She replied, "Am I allowed to?" I then advised the patient to contact his welfare officer, and he replied, "Well, I don't want to get into trouble." And it was as if he needed permission from me to ask for help. With getting them both on their phones and giving them hope and making them aware that they are not on their own, this diffused the situation. Unfortunately, I couldn't stop the baby crying, but 2 out of 3 isn't bad. The next day, I entered the ward and was met with a huge kiss and cuddle from the wife, not the husband. This is when somebody normally heckles me, saying I didn't get a kiss from the patient because he couldn't get out of bed. She said with just a couple of calls each, everything was sorted, and because I also spoke to the clinical staff, he was going to be transferred to a hospital near to his home that afternoon to ease the stress on the family. This is how the smallest of things, like identifying those in distress and simply making them aware that there is help out there, can make the biggest differences. And that's what I say to staff wearing this badge represents, because I have processes that also educate our veteran patients and families, and I ask them to make their military status known to a member of staff wearing the badge, with the intention of prompting the staff to record it. So I educate patients and their families as well as staff. And in closing, I also visit GP practices to encourage them to become veteran friendly. Why? Well, I once delivered a presentation to a GP practice and I was given feedback. that the very next day, after educating the GPs on the support available and the referral pathways, etc., a military family attended the practice with the husband in crisis. The GP in question told me that if he had not attended my training session the day before, he would not have known what to do for this family. But because he did know the current pathways, a plan for immediate support was instigated for him and his family. They have since applied and are now in an accredited, veteran-friendly GP practice.